So some of out-of-box thinking in pediatric trauma, situations are different many times, and what is written in textbooks and what is said in conferences sometimes may not work. And some, very quickly I'll show you some of the things which are out of the box, out of textbooks, which I do. Supracondylar fractures, Vidya Sagar covered it very well. A case like this, reduction is the first key, but the pinning, we, many times struggle with passing pins in the right direction. The problem is if you make multiple attempts, the lateral condyle, which is very cartilaginous, it gets tempered with, and then you lose hold on the K-valves. So what I do is something simple. You use a hypodermic needle, either 16 number or 18 number hypodermic needle, and with a hand put it into the cartilage of the lateral condyle, and then take your AP. So this is an AP which shows you this is the direction in which the K-wire should go, and the lateral shows you this is much anterior to where it should go. Now using this hypodermic needle as a guide, now you pass your K-wires. So this is how you will pass your K-wires with hypodermic needle in place. This is in lateral view and then in AP view. This is at 45 degrees, so this is a wire through the lateral column. And then you pass your other wire which is at 30 degrees, which is a 4 cortex wire. Now I have two sizes of K-wires, and this is not a mistake. It is not that I didn't have all the sizes of wires. It is done deliberately. Because when you have two sizes of wires on a lateral view, you will know which wire is which, and it will be very easy for you to negotiate. Okay? So this is how it is at the end of the surgery. These are two different sizes of the wires. Don't take only AP and lateral. It is important to take oblique views also, and we call them as max view. Max view is for the medial column. It is taken in external rotation. Limb view is for the lateral column. It is taken in internal rotation. So max view and limb view to look at the columns, because supracondylar fracture is a bicolumnar fracture, and column reduction is very important if you want to avoid cubitus virus. And always the slab or plaster, it should be given in 30 to 40 degree flexion after wiring, never in 90 degree flexion, because you will have increased chance of compartment syndrome. This is a distal radial fracture, with a very small ulnar fracture in a 10-year-old. How many of you want to cross K-wires? Anybody? Just raise your hand. Elastic nail, anybody? Elastic. The problem is this is a junctional fracture. The cross K-wires don't help. Elastic nails, for elastic nail it is too distal, for cross K-wire it is too proximal. And you will struggle passing and doing any of these techniques. Plating is an issue, is a possibility, because this is like a Galeazzi fracture dislocation, but plating leaves a long scar, and again you will have to choose a plate which will have barely two holes. Out of the box here, the first problem is reduction. Your milking maneuvers will not have, your joystick also will not help in these cases. To achieve reduction, what you need is pass two K-wires, one in proximal fragment, one in distal fragment, and then reduce it. So this is how you will reduce, with traction and translation. And once you reduce, you will use the same wires to fix it. So use 1 K-wire, join with a JS fixator, and pass a wire if possible across to stabilize this. Ulna will fall in place. Never fix an ulna with K-wire, because ulna is a shy epiphysis. The moment you pass a wire through epiphysis of the ulna, you will have ulna shortening. So never fix ulna in radius ulna fractures in children. And you don't have to keep this for long. At 4 weeks, you can remove the fixator, you can put the child in bone elbow plaster, and at 2 months you can remove the plaster and then mobilize. So this was one out-of-box situation. We are writing it up. Hopefully it will come in textbooks, and then it will not remain out-of-box. So this is upper ulna fracture from lower radius. Now we go to upper ulna, and it has radial head dislocation. So this is also fracture dislocation, Monteggia. So Viraj, how will you fix this? What is your choice? Plating or K-wiring or nail, Viraj? Pardon? Wires across. Yeah. So many options: plate, intramuscular nails, K-wires, for radius close or open reduction. So these are options. What I do again here is, again use my K-wires here, but not to fix across the fracture. 2 wires in proximal fragment, 2 in distal fragment, and then fix them with a rod. And I noticed that adequate reduction was not achieved. we got a reduction of the radial head, but length was not achieved. So then you put a temporary distractor, distract the ulna and get it in position. So you can see that there are multiple wires. These are all going through the ulna, and then there is an axial wire which is going through the intramedullary through the ulna, and this is also included in the fixator to give rise to stability. So this is range of movement which you can see, and okay, video not okay, and this is always confirm the stability of radial head in flexion and extension. So
thank you. Can I have the presentation? My train came. Maybe the presenting surgeon was not knowing the technique what Tarla has shown. So the options, as Tarla asked you that what one will go for this type of cases, and now you know the answer how to manage this case. But the surgeon who was treating, he was not knowing, and then he did the open reduction and the circlage wiring, right? So kneeling and the circlage wiring was put. So this is at the end of the 3 months, hoping that fracture will unite in a good position, or let's say something will not go into non-union. This is at 4 months, and then this is at 6 months. Okay, so naturally at this stage again, I mean, there are a lot of options people can think of, and this was the time when patient was presented to me that as Tarla suggested, one can go for distraction and then plan. So what we did in this case, we just opened the fracture, we actively distracted it, and we use a Ilekes graft, and we just shaped the Ilekes graft like a. Can you just play this video if it is possible? Yeah, and so it was shaped like a here, right? And we put a drill hole also, and then we could get the distraction. We fix it with the help of the plate, the recon plate, and we immobilize for some time, right? And this was till the union which is there. So I think around 2 months I had to, or 6 weeks I had to immobilize to get the union, and this was there at the 6 month. And this is 1 year, and this is post implant removal. It's doing well. It's 3 years now, the follow which is there, right? So the message for this case, as Tarla mentioned, you must be knowing what you are going to do, so that you are not inviting the trouble for yourself as well as for the patient. So do not take hasty decisions. Prepare yourself for whatever surgery you are going to offer to the child, and then only go for the surgery. Now this is the second case. This is a 14-year male child, 4-month-old injury, absolutely stiff elbow. I asked for the injury films which are, he presented to me 4 months after trauma. I asked the injury film, so the injury film which was there, it is like this. So what is this? It is an anterior dislocation of the elbow, which is very, very rare, along with the fracture of the medial epicondyle, or some portion of the condyle also you can say. And this, he was treated as classical by the quacks and tapes. They still have better practice than the orthopedic surgeon in India, right? It is like that. So this is the time when he presented to me, 4 months down the line injury. And can you play this video please? So see the stiffness which he has, and see the. So what is the solution for this case? We have a good collection of these dislocations, neglected elbow dislocations. So the textbook mentioned the posterior will go by the posterior approach, and we are not sure about the whatever the outcome which is there. So we go ahead with the medial as well as the lateral approach. What we do, we take a medial and lateral approach. From the medial approach, we just first protect the ulna now. Then we take the lateral one, we get the orientation, and then we take out the callus, and then VYplasty of the tricep. It is very important. If you do the VYplasty of the tricep, then you can get access to the whole of the elbow, and then you can free all over the adhesions which are there and the structures which are there, and then you can get a reduction. I will not go into depth of this because lack of time videos. And then we have to struggle for the medial condyle, and then we stabilize that fragment also. We have to transpose the ulna. It is very important to transpose the ulna, and this is post-op. The crux in these cases, if you get this kind of neglected elbow dislocation, you mobilize them earlier. So what we do, this is post-op. Can you play this video please? We just, after 2 to 3 weeks only, we take out the plaster of the slab, and we advise them to mobilize at home. Just play the next video also, right? So you mobilize the faster, you get a range of movement. So we teach them how to put a slab and then just at home and then mobilize twice or thrice in a day. Next please. So, and then the K wires were removed at 6 weeks, and this is a 8-month follow. Can you play this video please? And see the range of movement what the child has achieved, right? So this is still possible. If you act little earlier, mobilize. Next please. And this is follow. Can you play both of these videos? So even the stiff elbow, 4-month-old neglected elbow dislocation, we can still get this type of result. So go by the middle and lateral approach, and the crux is protect the ulnar now, tricepplasty, and mobilize early steps as possible. Okay. Now this suits to this topic very well. This is a child who had a fall from 12 feet with injury to the elbow as well as to the forearm. This was a entry and exit wound over there, and this was the elbow injury which was there. These were the wounds when he presented to us, and these were the X-rays. So what is there? Fracture supracondylar humerus, and here there is a fracture of the ulnar, right? So how to decide, what should the treatment plan? Anybody? Yes. So reduction in pinning, and what about ulnar? Compound injury, nailing, or you will like plating. Okay. Okay, nailing. Okay. So we did the close reduction for the supracondylar humerus, and we debrided the wound, the bad wound which was there, and then we thought that we have already opened it, so we put the plate which is there, 130 mm plate was put, right? Post-operatively there was no pain or the fever or all, like the post-op period was quite good, and after 4 weeks the pins were removed for the supracondylar part, and this was the X-ray, right? So looks still okay, and this is at 3 months. So the patients were happy, the parents were happy, even I was happy that everything is fine.
I request Dr. Veda Prakash sir to kindly honor Dr. Taras sir. Dr. Narasimha sir. Dr. Virat sir. Dr. Nagaraj, Dr. Durga Nagaraju sir. Dr. Vidyasagar sir. Dr. Venkatram sir. Dr. Roshan Jaiswal sir. Dr. Venkatraman sir. Dr. Roshan Jaiswal sir. Now I request Dr. Ramkumar Reddy sir to honor the chairperson, Dr. Srinivas Reddy sir. I request Ramkumar Reddy sir to honor Veda Prakash sir, Dr. Srinivas Reddy sir. Thank you, sir. Now we move on to our next session.
I am a self-taught pediatric orthopedic surgeon because in those days, the very first pelvic osteotomy convergence I did in England, where people were frightened to do pelvic osteotomy. That was in 1967 in England. That was in somewhere in Manchester Group. And we have gained a lot of experience in that, and I feel that in pediatrics, in children, they are monkeys, and monkeys cannot be prevented from doing wrong things. They should be jailed for a longer period, and that is highly important. You see, you must carry this message home. They should be jailed for a longer period. They should be restricted from movement for longer periods. And Allah usually doesn't respond to K-wires. You must use a plate. I'm glad that Shigade used a flexible plate and he could get away. And using surplus wire is something, I think I have not seen, I don't know how orthopedic surgeons can do that. I think surplus wires usually is like putting a noose around the neck. You shouldn't use surplus wire, as far as possible, unless you are forced to do it. Those three comments I wanted to do for today's presentation. Thank you so much. Thank you.
I thank the organizers for asking me to do this session. I am Dr. Srinivas Reddy, organizing chairman for coming OASISCON 2022 at Kannur, and the dates are September 2nd, 3rd and 4th. So I invite you all to Kannur for the OASISCON 22. Thank you. Thank you, sir. Next session.
I call upon the chairperson for the spine session. Invite the panelists for the session. Dr. Kiran sir. Dr. Bangari Swami sir. Dr. Raju Iyengar sir. Dr. Suresh sir. Dr.
I'm going to present a case on lumbar canal stenosis. So it's a case of 45-year-old gentleman, electrician of profession, and mainly complaining of back pain, more of bilateral sciatica since 7 months. Patient had neurological claudication since 5 months, and he is on conservative line of treatment in form of medication, physiotherapy, but they from 5 months, but no relief. His symptoms were progressive in severity, and at present, when presented to me, his claudication distance was around less than 100 meters. So on examination, there were no medical comorbidities, and there was tenderness over L4 and L5 spinous process area and paraspinal area. Bilateral SLR was 60 degrees, and his Milgram's test was positive. That's a bilateral active SLR. On neurological examination, there was no neurodeficit, and patient was self-voiding. And patient presented to me with a direct MRI LS spine. So this is MRI sagittal view T2 section, where we can see canal stenosis at L4-5 level. You can appreciate it more here with left side foraminal stenosis. We see traversing from right to left, And coming on to his axial sections, there was a severe canal stenosis in the L4-5 level, and you can appreciate more here with facetal arthropathy and facetal effusion. So, how to approach to this patient?
Fortunately, a very senior spine surgeon said on the opposite side, right? I can't ask them about taking flexion extension x-rays, standing x-rays, all that. You need to get on to really spine data now. They are not youngsters. Yeah.
Yes, I think you should put up the X-rays and then you
Yeah.
come back and tell us what is your dilemma in managing this patient.
Yeah, sir, actually the main intention of presenting this case was, patient presented to me with direct MRI, and many of the, seen by many of the doctors who told just decompression, few told with stabilization, and few told that we need to fuse it. So, whether directly going for surgery or whether to investigate further, that was the only message of this case.
As a spine surgeon, you have to take the X-ray.
Yes.
Even if he comes with 2 MRIs, you have to take the X-ray.
Yes, sir, that was actually main message of the case. So we got his dynamic X-rays where you can see on flexion, the L4 vertebra is moving forwards, like there is a listhesis. You can appreciate it more here. And on extension, that the listhesis is getting reduced. It's a dynamic instability on flexion and extension view. So this is the case. So
Okay, let's start with Dr. Kiran Lingutla. Have a microphone?
First and foremost thing, you'd like to see a AP X-ray as well, because when you saw the MRI, the last L5S1 disc, what we think is L5S1, is well hydrated. We don't know whether that's fused to the pelvis or not. Rest of the, yes, rule out cyclization first. And also you need to get the levels correct as well. So if you have any AP
sorry,
X-ray,
sir, actually I have not added in this. We have APX, so there is no cyclization.
okay.
Yeah,
So that is L4 file level.
that we have checked.
Okay. And
From C1.
Yes, sir.
They are infiltrated.
No,
There's no C1 in your
no
MRI.
C1 film, sir. There is
There's no C1.
yeah. And many of the things, like when we tell the patient to get a fresh, that's a recent MRI, sir. When we told that we need a scout film to count, patient usually with the financial constraint, they won't get encouraged to get again a repeat scan. So
so we take this as L4 file with some amount of listhesis, that is minimal listhesis. And you also said that there is no back pain to start with.
no, sir. Patient has was complaining more of claudiculopathy and sciatica than back pain.
Okay, so symptoms are more predominant than your back pain.
Yes, sir.
At the first instance, like you should have a dialogue with the patient to see what you want to treat, because the age group of the patient was
45 years.
45. So he's quite next.
And an electrician by profession who like standing work,
Correct.
sometimes lifting heavy equipments.
Correct. So you should be more targeted to his symptoms rather than what the scan shows. You could start off with doing pain blocks first to see whether that, this is not an emergency as such. If his bladder is fine, you do some, if the bladder is fine, you should do some pain blocks and see whether the epidural relieves of symptoms. So an isolated decompression is a fairly good idea, because he's a working gentleman. You don't want to fuse his spine at such an age, and take it forward from there. But also talk to the patient first and tell him what are the options that we can do. And you should always take him on board before doing anything.
Okay, 2 things I would like to mention, because this spine session is slightly complicated for the non-spine crowd here. In orthopedics, forget about spine. You never ever treat a patient without an X-ray. Never. Anything in spine or in the rest of the body, it has to be an X-ray. So in fact, X-rays give a lot more information than MRI scans. MRI scans for a simple disc have a false positivity and negativity of about 25%. They can mislead you completely. So always X-ray scans. And please don't say that he is a poor patient. Please. There is nobody poor in Telangana. Either the government supports or we support. It doesn't matter.
Sir, one more.
all our patients can afford X-rays and MRI scans, and we should do every investigation. Just few days ago, there was a consumer forum case with your line of management. Conservative means non-instrumented surgery.
The fluid signal in the facet is not more than 3 to 4 mm, but still it is getting correlated in the flexion and extension X-rays with dynamic instability. So for us to think on MRI in facetal effusion, if it's unstable, it should be more than 3 to 4 mm of effusion, that we are not able to see very frankly here. So it's a one level dynamic instability on flexion extension X-rays with significant stenosis on axial sections. If this patient doesn't get better with conservative line of treatment, it's very result-oriented surgery to do decompression and fixation and interbody fusion. A good spacer, interbody spacer with anterior bone graft, and either conventional technique of TLIF, midline open, or minimal invasive TLIF can do a good justice to this situation.
Devanand, would you instrument it or would you not instrument it?
Sir, I would take 2-3 things into consideration.
What would you do now?
I would fix this. I would fix this because the sagittal facets, facetal effusion, facetal arthritis, and at the same time there looks like to be a cyst on the left side. So I would fuse it.
I would definitely fix this in a conventional way because I am more, experienced in that. Considering the dynamic X-ray, if you see the junction of the dorsal-lumbar spine, there is verging of L1 and L2 that indicates that he is a manual laborer. That we should give a very good, stable, painless. Therefore, L5 segment, I would definitely fix with. I do TLIF and the fixation because there is instability in dynamic X-ray and is a manual laborer. He has to go back to his work, and the facial effusion as well as the cyst. Considering all these issues, we have to go for fusion. It all depends upon the surgeon. Yeah, I'll do TLIF with from left side.
Yeah, tell us in 1 minute, 44 seconds what you have done.
Sir, what we did is, as I told, so this is what we did, sir. We did L4-5 stabilization and interbody fusion with a thorough bone graft. And this is at the 2.5 month X-ray. There was enough graft left, so we also did posterolateral placement of the graft.
I would not have picked it. I would not have picked it. I would have done bilateral foraminal laminotomy and did a focalized decompression. What, Dr. Kiran? Agree with me? Because what happens, adjacent disc degeneration will happen very fast in electrician. He'll come to you for surgery again after 10 years.
Yes, sir.
That is the way he is ensuring his practice to carry.
Yes, sir.
Anyway, thank you,
till the time I have to.
It's a very great, good case to discuss.
Yes, sir.
And I think quickly we'll go with Dr. Ramakrishna.
Thank you, sir.
He is going to present a case of lumbar spondylolisthesis.
Everyone, respected chairpersons and panel members. So this is a simple case wherever a spine practice or a neurosurgeon or orthopedician come across. And this is not about how good the case has gone, and this is all about how a simple case can go wrong in different ways. And this is a case of my colleague neurosurgeon. So he had operated this before, which he's concerned since this educational platform have started presenting this case with the suggestion of Murthy sir. Thank you for it. And I would like to know the comments from the experts at what all levels we can correct the mistakes which would happen. And she's a 27-year-old female with pain in the lower back, radiating to left lower limb. The symptoms were since 2 weeks, which was sudden in onset. She came with a history of complaints 4 months back, similar complaints, for which she was operated by my colleague neurosurgeon. And on examination, there was scar over lumbar spine and there was tenderness at the lumbar region. And we had only MRI and only the post-op X-ray. This was the X-ray which was done after surgery, where the fusion was not done. There was only reduction of the listhesis with stabilization, and there is no interbody or posterolateral fusion. And after the complaints, when she came to the hospital, this was a scenario where there was an implant failure, the screw breakage on the right side. So the listhesis has worsened. So we had a discussion about the old case which she has done, the open mind and open free to accept the comments. There was no bicortical purchase of S1 screw and no interbody fusion, and the L5 screw which was a bit lateral on the left side. So probably because of which the implant failure has happened. And he has tried to fix it till from L4 to S1, but he couldn't do it as on the left side there was a pedicle breach, so he left it there. So we have done extension of fusion. On the left side we couldn't get a pedicle, so this is what we have done, and too enthusiastic to put in a lot of graft interbody, and the cage you can see is a bit lateral, and we tried to pull out the cage, but it was not coming because of the too much of grafting, and the too much of impaction of the cage was done, which has entered the end plate. You can see after surgery the symptoms were improved and patient was mobilized on first post-operative day. After 2 days the patient has developed paresthesia in the left lower limb. So we went back and looked into the X-ray, and the CT was done, and this is the position of the cage, which was too lateral, and which is fixed into the end plate. During surgery we tried a lot to pull the cage out. It was fixed there, and we thought to leave it there, but after 2 days she has developed this pain after mobilization. And we have discussed with many spine surgeons across Telangana. Then some people have given local anesthesia, but we have decided to take it out since he was under a lot of pressure from the patient. Then this we have re-explored, and we could find that the cage was broken. That was a P cage. The broken piece was fell apart onto the lateral side, probably it was irritating the plexus, and we have drilled and removed the cage, and this was post-operative after removing the cage. So is it sufficient, or do we have to do anything extra for this case, of like from the experts?
Raju sir, can you?
Yeah, actually at the outset the first thing what was noticed bicortical purchase of the screws, and that was what was coming to my mind, and no fusion initially. So L5 S1 always try to do, even a soft fusion works there, not necessarily put a cage or something else, even making the distress and then putting some bone graft, nice packing the cavity bone graft, that works. Without fusion, definitely L5 S1 is going to create a problem. That is what has happened at the initial stages. No bicortical purchase and suboptimal fixation. What comes to my mind?
No one, any comments?
Same as Raju sir.
Brothers, you want to talk?
I just was looking at S1 screw on the left side. It is too divergent for an S1 screw to be like. It has to be convergent, and we have seen quite often divergent S1 screw irritating in front of the ELA, the S1 root on the left side. So that also needs to be carefully looked at.
After removing the cage, the patient was asymptomatic, and she had good relief in the symptoms, and she was mobilized, and she was happy. No complaints to
But the divergent S1 screw on the left side still is not an standard place of putting the S1 screw.
Since there was no symptoms after removal of the cage, we didn't think about this one reposition.
My question here is, because you had a pedicle blowout on one side, you extended your fixation to L4. Why you did not recruit both the pedicles, or this was the neurosurgeon's choice?
This was L4 pedicle was broken.
Yeah, but you went one level above.
Yeah.
So why did you not recruit both?
Yeah.
Both. Why you recruited only one? That means your colleague is still controlling you.
pure pedicle can be put transpedicular screws or extrapedicular also you can put, no?
But it's not so.
Who told you? Next it will hold. Because others are holding, no?
Is that L4 screw blown out or L5?
L4 screw was blown out, but L5 screw was outside. Screw was outside.
On the left side L4 was blown out. That's why it did not extend to L3.
Welfare we can salvage if once the screw is broken, pedicle is broken. There are so many methods to salvage the screw on that side. If the surgeon is experienced, the entry point can be changed, and you can use a longer screw or entry point can be changed to the second time would have done a better job.
Number two, whenever you are doing a T-lift with a titanium gauge, you can hit it hard as much as you want. But when you are doing with a polyurethane ketone gauge, peak gauge, whether it is reinforced with carbon or whatever it is, it should glide in smoothly. The gauge broke because you hit it doesn't break on its own. And whenever you are not confident about the gauge position, always use a titanium gauge. People don't use a titanium gauge because patient comes to know that the gauge is teda meda. So put a peak gauge, neither the doctor knows or the patient knows. Where is the gauge? You got it? And you should know how to read the markers. The gauge has 3 markers. If you don't know how to read the markers, so before closing, you will not know where the gauge is. So first learn how to mark the markers. Once you learn how to mark the markers, before closing you will know that the gauge is not there.
Intraoperatively, we have noticed that the cage is lateral, sir. It's in the markers, but we have tried to pull it out to reposition the cage, but it was fixed. Yeah, we have done all the methods, distracting, but we couldn't pull it out. And it being a redo. Yes.
All is well that ends well. What is the lesson that we learned here? It is in your first statement. Anyone who tries to reduce a displacement without fusion is unthinkable. Unthinkable. So what this gentleman has done is put 4 screws and maybe decompressed it. By doing that, he's actually added more instability into the situation. So any time you want to correct a deformity in spine, you have to add a fusion to it. That led to all these problems. We'll move on to the next case.
I would like to ask one this thing, sir. Should we leave it here or do you want to do anything about this case? Do you want to extend it more proximally or leave it like that? No. The patient came after still 7 months. She was very happy, thanking the doctor. And sorry. So this was the scenario after 7 months.
It is an oblique X-ray. You really can't make out much in that. But I think Devanand can put some light on this.
Sir, first thing is I will try to put one more extra pedicular screw at L4, and if I am extending a level, I will make sure that I will put a cage at L4-5 also. And while removing the peak cage, as sir pointed out, we should not hit hard. And I always take care that I distract before putting the cage, ream one level above. Like if I am planning a 10 number cage, I will ream till 11. With 11, if I am able to see the end plates good, I will put a 10 number cage and then compress it good so that it doesn't come back again. So in this case, I would have done L4, L5 and L5 S1, 2 level interbody fusion, so that in the young patient like this, and the screws L5 doesn't look converging. So they're just on the lateral wall and they may break any time and it may lead to a situation like this with an implant failure.
So this is the end of the story?
Yeah, this is the end of the story. I would like to know the comment. What to go about next case?
It's a basic orthopedic principle that if it is not used, it will fail. So, I mean,
And then, sorry interrupting, and it's a very strong message. Orthopedic should be done by orthopedic surgeons, not neurosurgeons.
yeah. Okay, thank you, Ramkisha, for a beautiful presentation. Next we follow from Dr. Sridhar Reddy for the case of cervical disc. I think something similar to what Ramkisha presented, I guess.
Do you go months? He had instability while walking, and it had just progressive instability. Bilateral hand grip was 4/5. Bilateral, all the flexors were brisk, and even lower limbs were weak. This is the
So this is the initial MR scan?
yeah.
What was that? How is it?
This was the thing.
This was there any comments? Now patient landed to us. No, it was graft is there, sir. Graft is there. Graft is there. ACDF was properly done, but patient landed with quadriparesis with me right now. At this with this X-ray, okay, right. With this X-ray, patient came to me with quadriparesis 2/5. Quadriparous bilateral upper limb for 2/5, reflexes segregated. What next? Swami sir, any comment?
First of all, there is no CT scan. Before attempting the first time, you should be very clear whether it is a hard disk or a OPLL developing opposite to the disk. So there is, do you have a CT scan?
33 years old male, all discs were well hydrated.
Okay, do you have a CT scan? Okay. That is the disc was hard?
I did not do that. See, it's a, I mean,
No.
Yeah, this, yeah, sir. This is the MRI. Yeah, not okay, right?
Is your upper limbs are spastic now?
Now both upper limbs and lower limbs.
Both upper limbs and lower limbs. But the symptomatic level may be at the same site, at C3, C4 level. So you don't have CT. Did you do CT now?
Yeah, he came with CT after surgery. This is how many days post-op procedure? Next 1 week. 1 week, 10 days he was right.
The possible
now CT was done.
Okay.
So
yeah.
it was a hard
This
disk
is
as Dr. Bangar Swami was suggesting. But 33 years old male, usually young patients, they do not have such a bad disk, 1 level. Can it be OPLS?
This is do we have a total sagittal, a whole spine sagittal CT scan?
This is the pointer,
This could be a tandem stenosis because of OPLL, or a patient might be a fluorotic or having a signs of skeletal hyperosteosis or dish. Some syndromes of skeletal hyperosteosis, maybe dish or fluorosis or AKS also we should not,
Yeah. Yeah, that's what. So
now this weakness might be contributed to the surgical insult or maybe post-operative edema after surgery. Or if the symptoms in both upper limbs and lower limbs are spastic, the site of injury might be at the same post-operative level. Suppose as Raju sir suggested, the upper limbs are not spastic, the second level, once the higher level has operated, the second level, next cranial level is D1, D2, that could be the reason for his weakness. Then we should address that. But now, as after this, because upper limbs are spastic, it is from that level now.
Very common in these situations. See his breathing and take the help of intensive care specialists, optimize him, and then do the surgery. And I think if you go posterior, you should have a good broad fall back. Localized decompression is again will cause more problems.
Sir, your colleague, and she is a diabetic and hypertensive. She is having a neurology at the time of presentation according to his history. And pain was classically increasing on turning in bed and standing from sitting position. These are the initial MRI and CT scan. This is done after 4 weeks. Initial X-ray was taken, which is also.
No, the main complaint is lower.
Back pain, and it is increasing. It's not reducing. Conservative treatment of rest and teriparatide was given. And so she is a very obese lady, and they don't want to continue more rest after 4 weeks. Like she's already having one complication.
Do you have any other?
Axial CT is there, but yes, sir. Only slight break in the bone. Yes, sir, yes. It was done. The axial CT is axial only, as we know, and it was not showing any retrobulge.
Nothing,
Yeah.
I mean, nothing significant on MR.
Yes,
Other
sir.
than this. Okay.
So, CT axial is done. These are the reconstruction.
But your condition is osteoporotic. You are not.
Yeah, definitely.
His
His BMD is minus
So it is not
3.5.
multiple myeloma. Second electrophoresis is
Yeah.
normal. Everything is normal.
Yes,
ESR is
X-ray
normal.
of pelvis is done.
Because so many things mimics osteoporosis. So many things mimics osteoporosis.
Yes, this secondary it can be.
So whenever you see a 60 plus, then don't jump it is osteoporosis.
Yes.
You have to exclude everything to come to the conclusion that it is osteoporosis. So you treat everything.
No. Initial with presentation, once when it's not.
I come across multiple myeloma left, right, and center.
Yes, sir.
Every day in my life.
Yes, sir. This patient was
being treated with teriparatide, and teriparatide is a strong contraindication for multiple myeloma.
There are two parts in this case. This is treated by another surgeon. So the details which are available, I have kept it here. And so as far as I have had a discussion with him when this patient came to me, so he treated it as an osteoporotic fracture, and there are no other findings which are correlating to multiple myeloma. And she had a history of fall followed by this fracture in an X-ray, and this is the 4 weeks MRI and CT scan.
Next.
Yeah. Minus 3.5. So he treated this patient with a vertebroplasty. Sorry.
Go back.
This is not going back. Go back. Yeah, there is, it's not going back.
Now, a couple of things to the younger guys here. Not every, Dr. Dinakar is saying, not every osteoporotic fracture is due to
Go back.
weakness of the bone, number one. And teriparatide starts working like 3 months.
Can you go back?
Go back.
And its action on the bone
Back.
starts around 7 months. To be effective.
Go back. Yeah. Keep it there.
So now we have a lot of literature on
This was done by.
Yeah, this was done by them.
Okay.
So. Yes, sir. No, I think that she was fine after the first surgery. And as we can see, there is leak into the pedicle.
That's what.
Into the pedicle, but not in the canal.
Okay.
Yeah.
How many of the panelists think this would work in this lady who is obese? And I can't see the images. Yeah, it looks like there's a cleft that is going into non-linear. Am I right? So it looks like there's a cleft there that's going into non-linear.
Just one question, they attempted vertebroplasty or kyphoplasty?
Kyphoplasty. Yes.
That's why it's.
Does any of the panelists believe that that's going to work as a modality?
No, this one.
At this level, at junctional D12 level, because the stress and strain are very high, that is the reason it was fractured. The D12 is fractured because of high stress at that region. When all conservative modalities are not working, if you see primarily, it is better to go and fix 2 levels above, 2 levels below. And if still it is weak, then you can do intraoperatively open vertebroplasty and come out. That's fine.
Back. Go back. Yeah. We didn't have the X-ray.
Pseudoarthrosis. It's a split cleavage type of fracture, completely burst. It has to be fixed.
So after this, patient was fine. She went home, and she presented after 3 months with weakness in the lower limbs and back pain. So on my examination, when she came to me about 3 months back from now, so her power was around 2 to 3. She stopped walking from last 7 days. Suddenly, it's not gradual weakness, and the whole limbs are spastic. Sensory level is L1. So this is the MRI which I got done. So and CT scan was also done, but I couldn't find the reconstruction. So you can see there is cement in the anterior part, and I think the panelists should comment what we need to do.
Everything is inside the canal, like I told you. Recently, I read an article. They removed a cement from right atrium.
Yeah, that is.
This vertebroplasty, kyphoplasty has done very deliberately. They removed a thin strip of cement from the atrium, and when they found it in the history, they found it here at vertebroplasty one.
You have any CT, Chaitanya?
CT is there, sir, but patient is not having any fall or injury, but this happened suddenly when she was unable to walk, but she is moving her limbs. So on my examination, because she is very old, like 70, 72 years,
Just
so
like,
she came on a wheelchair.
Just like Raja told now, they have thrown a stone into a big side.
Devanand, any comments you want to make?
I would like to focus on 2 things here.
if you go back to the X-ray, there are two things which orthopedic surgeon need to know. It is intravertebral instability and intervertebral instability. So whatever is intravertebral instability, there will be a cleft sign on the X-ray and also a fluid sign on the MRI. And the CT scan need to be done when all the cortices around the cleft are intact. Then only you should plan for a vertebroplasty. If there is a cleft which is going into the disc, that means it is intravertebral instability. Whatever cement you put in and whatever consistency
and hand angiomas since last 10 years is Murex grade 3 actually. Japanese orthopedic association score is 11, class is 5, and there is no OPL, levels of OPL are C2 to C5. This is K-line negative. On flexion and extension, we have 0 extension with 8 degrees flexion. The neutral is around 3 degrees.
Can you go back?
Yes.
Can you go back, please? Go back. One more. What are the main complaints, Srinath? I mean, it's only grade abnormality or any paresthesias or
The spasticity, the deep tendon defects are exaggerated, and some sort of radiation is also.
Oh, radical syndrome is paresthesis.
Devanand,
any comments from you?
So my
please, Srinath, go
the
ahead.
dilemma is the approach of the surgery, whether to go anterior or posterior.
Yes.
You want to do anterior or posterior?
With the clinical symptoms called being compressed at more than 2 levels, the rule of thumb is more than 3 levels, we need to go posterior. And looking at the continuous OPLL at C23 and C45 with cord compression, I would like to go posterior without any doubt. Right from C2 to C6, I would like to decompress. At the same time, this OPLL is a continuous type of OPLL and would progress. So I would like to fix it so that the OPLL doesn't progress. And at the same time, I would like to look at the whole spine MRI to rule out any other similar kind of picture in the dorsal and lumbar.
There's no other compression in the dorsal.
Dr. Kiran Lingutta, what do you want to do here?
So my thought process would be, of course, choosing anterior or posterior. Look at the lateral of the X-ray of the C-spine. If it is neutral, it is close to neutral. Yeah. It is. We can take it as a neutral lateral C-spine. This would be better approach posteriorly, I would have thought. If it is kyphotic, then you have to do both a corpectomy in the front and augment with the posterior decompression stabilization.
Yes, sir. Posterior. All 3 of you posterior. Right. Anybody wants to become a girl? Srinath,
Anybody for multi-level anterior?
But just for the discussion, sir, I have one doubt. So, because symptoms are related to 4-5 level, it is not because of C2 level. So, instead of doing high-level corpectomy, why can't we, if anteriorly contemplated, because it is just about to, come to kyphotic position, to attack pathology directly, we can go for C4 corpectomy and do a stage 1 decompression, because it addresses the pathology anteriorly directly, and at a later stage we can go and do a posterior. Once surgical alignment balance is achieved from front, later date we can go and do a laminate.
Do we have the transfer sections at each level?
Could not retrieve good quality axial images.
No, see, the entire pathology C4, C5, there is significant compression. I think that has to be addressed. And taking into consideration if it is a multi-level pathology or not, it is very difficult to make the decision unless you see the transverse sections. Many times what happens is, sometimes we think it is a sagittal section. At one level, maybe there is a little bit coronal tilt of the spine. One level you get a perfect sagittal section, other level you get a parasagittal section. This is actually many times we mistake. This is a very common problem whenever we see long sages, where especially we see it could be a significant OL in the thoracic spine in one of the sections. The moment you see the transverse section, you know.
Go back 8, see there.
which is radiating to right lower limb. So there is a history of night rise, there is a history of evening rise of temperature, and the loss of weight and appetite. So on examination, patient looks emaciated, pallor, there was tenderness present in the lumbar spine. Apart from right EHL weakness and sensation decrease in the right head abutum, the rest of the neurology is normal. So I have done some investigations, which was hemoglobin 7.1, TLC 4000, ESR and CRP elevated, and I have done a chest X-ray also. So they have the cavities in the right lung apex. So I have done a X-ray lumbosacral spine. So it shows grade 1 anterior listhesis of the L5 or S1, decreased space in the L5 S1 disc space, and some erosion of the implants of the inferior implant of the L5, and S1 is not implant of S1 is not visible. So I have done next I have done.
Go ahead.
So next I have done MRI. So this is the T1 weighted and the T2 weighted images. So it shows the T2 weighted images with hyperintense in the L5 and the S1 with the perivertebral and the epidural abscess. Even the dissection involved up to S3. And the screening shows some end plate changes in the L2 and L3 also. So I have done a stereo. So you want back sir? So these are T2 weighted and T1 weighted. So these are still images. Sometimes you can miss in T2 and T1 weighted images. So in the still images we can see clearly that there is involvement of L2 and L3 also. So the patient now has L2, L3 discitis and also L5, S1 discitis with instability at the L5 and S1. And he is a laborer by occupation. So,
sir, Iyengar sir, you want to follow? You had any scout film?
I have an MRI. There is no other lesions in the rest of the spine.
Okay. Pawan sir, comments?
So before going for the treatment, surgical to management, I will definitely go for the biopsy, and based upon that only I will start the treatment because I had a bad experience.
Any other comments from panelists? Sorry sir?
Because there being multiple lesions, basically tuberculosis is a medical disease. Before jumping to any kind of surgery, first confirm it whether it is really tuberculosis or some infective spondylodiscitis. Nowadays, because of post-COVID, we are getting, because of patient has received so much of loads of steroids, patients are coming with this kind of picture with spondylodiscitis infective. Infective because of staphylococcus or some other thing, bacterial spondylodiscitis. Before that, we should confirm the diagnosis by needle biopsy. If the biopsy revealed it is pathological tuberculosis, still we can go for 3 to 6 months of medical management for AKT. Wait and see if the symptoms resolve. We can leave it like that. By any chance, if there is any neurological deterioration in future course or involvement of other lesions during the course of follow-up, then we can go and do in most symptomatic level surgical management. Still continuing the ATT.
There is an antrolisthesis, so can we leave it or should we stabilize in these type of cases?
Absolutely we can leave it. And the tuberculosis, the end point is bony fusion. It will fuse like better than global fusion. It will feel better than global fusion with good ATT. The canal is cleared and canal become normal within due course of
The
time.
natural course of TB is autophagy.
There was a foraminal stenosis also.
You just put him on medical management. How many doses? No, he is not.
So with the gene expert, we can know whether there is a recurrent resistance or not, so that we can start first time.
I mean, this is the first, the patient came to you.
This is the first initial case.
I mean, any biopsy was done for you?
No, sir. So I have done an open biopsy.
Go back to your X-rays.
Please, sir.
X-rays, post-op. Post-op
X-rays.
Yeah, no, next. Yeah, see, you have fixed right from L1, L2, L3, L4, L5, S1. You have essentially completed his lumbar fusion. And now my question here is, technical aspect of the surgery is very good, but the philosophy behind the surgery, what prompted you to take such an aggressive action?
Because of he is a laborer, so I want to have a stable one. So I have done a fixing. Because I want to mobilize him early.
I think a panel can say about it. Dr. Kiran Lingutla first. Would you do such an aggressive surgery in this patient?
Him being a laborer, probably not. Probably I would have gotten a CTA before the surgery itself. If I can get away with isolated 5-1 fusion with a good iliac crest bone graft at that level and do a isolated decompression and the level above if you think there is cord compression and put him on antitubercular and antibiotics to treat his pathogens. That would be a fair option at all.
Dr. Raju?
Yes, sir. L5S1 fusion. And probably 2 levels, not another 2 levels I would have said. 2 levels above. Lower one is okay.
Any one of the panelists who would like to go all conservative for this?
Yes,
I
sir.
want to ask this question. What some hands are being from the audience.
Okay, sir.
For not distance sake. See, I would have gone conservative.
Sir, if the patient is having unrelenting pain and if they insist for surgery, then we can go for L5 posterolateral fusion.
I have hardly seen any patient insisting for surgery to go.
The patient has unrelenting radiating pain, sir. It's not at all